Hello everyone, welcome to this online section on Retinal Artery Occlusion, RAO. I'm Dr. Hao-Yu Chen from Joint Shantou International Eye Center, Shantou University and the Chinese University of Hong Kong. An 82-year-old gentleman presents with a sudden loss of vision in his right eye 6 hours before. He had a history of transient vision reduction 3 times in the past weeks. The symptom lasted 10 to 20 minutes and resolved spontaneously. He had a history of hypertension and hyperlipidemia. The best corrected visual acuity was hand movement in the right eye and 0.7 in the left. This is the fundus photo of the right eye. What's the diagnosis and how do we manage this patient? These are the learning objectives of this section. You will understand the risk factors of RAO, can describe the clinical manifestation and management of RAO. Let's review the anatomy of retinal artery. The central retinal artery is a terminal artery. It means that there is no collateral connection and severe ischemia will develop if there is an occlusion in this artery. Another important point is that the central retinal artery only supplies the inner layers of the retina, from the internal limiting membrane to the outer plexiform layer. The outer retinal layers, from the outer nuclear layer to retinal pigment epithelium, are supplied by choroidal vessels. The ophthalmic artery is a branch of the internal carotid artery. It divided into the central retinal artery and posterior ciliary arteries. The central retinal artery has several branches in the retina. Therefore, according to the site of occlusion, there may be ophthalmic artery, central retinal artery, or branch retinal artery occlusion. In some patients, there is a ciliary retinal artery which does not originate from the central retinal artery, but from the posterior ciliary artery. Therefore, there may be CRAO with ciliary retinal spreading or solely ciliary retinal artery occlusion. I will present the clinical features of these diseases one by one. There are several pathogeneses in RAO. The occlusion may be caused by thrombosis, a blood clot, resulting from risk factors such as hypertension, diabetes, hyperlipidemia, hypercoagulated status. The second cause is an embolus, which may come from the heart or internal carotid artery. The third one is vasospasm, which usually causes transient ischemia. The fourth is arteritis, which is generally seen in autoimmune vasculitis. Some RAO may be iatrogenic, for instance by cosmetic facial filler injection. RAO usually occur in elderly patients with no gender preference. The visual loss is acute. Let's look at the fundus photo of our case. It is a typical image of CRAO. The main feature is the whitening of the retina. Let's compare this photo to that of a normal eye. The normal neural retina is transparent. The brown color is the color of RPE and choroid. In CRAO, the neural retina lost transparency and appear as white color. Therefore, we cannot see the brown color of RPE and choroid, except at the fovea. There is no retinal vessel in the fovea, so it remains transparent. We can see a cherry red spot at the fovea. This is the optical coherence tomography (OCT) of this patient. The light comes from the above and the refracted signal are recorded. Let's compare it to a normal OCT. We can see that the refractivity of the inner retina is low in normal OCT. This is because the neural retina is transparent. While in CRAO, the refractivity of the inner retina increases, suggesting that it has lost transparency. The RPE, which is at the outer retina, has high refractivity in the normal eye but reduced refractivity in CRAO. That's due to the opacified inner retina blocking the light. You can also see that the RPE of the fovea remains highly refracted because there is no inner retina layers in the fovea. This is the Florence angiography of CRAO. It shows delayed filling of the retinal artery of the right eye. This is a fundus photo of branch retinal artery occlusion. We can see that the superior part of the retina is affected and the inferior retina remains normal. The cause is an occlusion of the superior temporal artery. This patient has CRAO with serial retinal artery sparring. This artery does not originate from the central retinal artery, but from the optic disc. Therefore, it is not affected in CRAO. We can see the part of the retina supplied by the serial retinal artery remains normal. But we can also have serial retinal artery occlusion like this one. Only a part of retina supplied by this artery is affected. After the acute stage, the retina gradually recovers transparency, but there is atrophy of the inner retinal layer on OCT. RAO is an emergency. The management of RAO should be prompt for acute patients. Several methods can be tried to restore retinal perfusion. The first one is vasodilators. Sublingual isosorbate nitrate should be prescribed. Intravenous or oral vasodilator can also be used. Inhalation of a carbogen hyperbaric oxygen can also dilate vessels. Ocular massage and anterior chamber paracentesis can lower the intraocular pressure and dislodge the thrombosis or embolus. Systemic or local thrombolysis can also be tried. Besides the acute management, prevention of other vascular obstruction is also very important. RAO shares many risk factors with other vascular diseases. Therefore, a systemic investigation should be performed to identify these factors. ESR, CRP, and platelet counting should be performed to exclude arteritis. Blood pressure, glucose, and lipid profiles should be tracked. Doppler carotid ultrasound and echocardiogram may identify the source of the embolus. Young patients should be checked for hypercoagulatable causes, autoimmune antibodies, and hematological disorders. Okay, let's summarize today's section. RAO have several systemic risk factors. Investigation of these factors would help in preventing other vascular occlusion. The onset of RAO is acute. There is a loss of transparency of the inner retina. OCT and FFAA can help to identify RAO. In the acute stage, several methods can be used to restore retinal perfusions. Thank you for joining us. Here are some references for further reading.